All right, let's dive right into this. Welcome, everyone. Today, we're taking a comprehensive, top-down look at one of the absolute most critical topics you're going to face both in the clinic and on your board exams. We are talking about glaucoma. Now, think of this explainer as your definitive residency board review masterclass. We aren't just going to sit here and memorize isolated facts today. No way. We are going to trace the biological continuum of this disease. We'll start all the way down at the foundational physical laws of aqueous flow, we'll build that up through the anatomy and pathophysiology, and then finally, we'll arrive at the clinical algorithms you're actually going to use to diagnose and manage your patients. So grab your notes, get focused, and let's master this together.
So here's our roadmap for today. We'll be hitting 1. Defining the optic neuropathy, 2. The Goldman equation, 3. Anatomy of aqueous flow, 4. Structural and functional damage, and finally, 5. The diagnostic algorithm.
Okay, let's kick things off with Section 1, defining the optic neuropathy.
I want you to read this definition carefully with me. Glaucoma is a group of optic neuropathies presenting with progressive optic nerve head damage and characteristic visual field loss. Notice what is completely missing from that sentence. Do you see the word pressure anywhere in there? Nope. And this right here is a massive classic board trap. Do not confuse the definition of the disease with its risk factors. Glaucoma is an optic neuropathy where axons die. That's it. Elevated intraocular pressure, or IOP, well, that's simply the strongest risk factor for the disease. In fact, a patient's IOP can actually be entirely normal or even low, and they can still have glaucoma. But, IOP is totally unique because it's our only proven modifiable risk factor. Since manipulating pressure is literally our only way to stop that axonal death, we got to understand exactly how IOP is determined in the first place.
Which brings us right to Section 2, the Goldman equation.
Okay, I want you to build this mental model in your head right now. It's super important. The Goldman equation basically dictates that IOP equals a fraction plus a number. The numerator of our fraction is the aqueous formation rate, measured in milliliters per minute. The denominator, that's the outflow facility. And notice that if you divide the numerator by the denominator, those milliliters per minute units perfectly cancel out, leaving you with millimeters of mercury. Then finally, we just add the episcleral venous pressure, or EVP, at the end. So what's the big clinical takeaway here? Well, if you want to lower a patient's IOP, you literally only have 3 physical options. You either decrease the numerator by stopping aqueous production, you increase the denominator by opening up outflow, or you decrease that EVP addition at the end. That is the whole shebang. Every single treatment we have relies on this exact math.
Let's go ahead and apply that math immediately to our pharmacology. How do our daily eye drops actually manipulate this equation? For our numerator reducers, the drugs that decrease aqueous formation, just think of the mnemonic BAC to the tap. Beta blockers, alpha agonists, and CAIs take a BAC to the tap, essentially turning off the faucet to decrease fluid production. Then we have our denominator increasers, the drugs that open the drain to increase outflow. Those include your prostaglandin analogs and parasympathetic mimetics. Now pause for a second. Here is a super high-yield OKP pearl for you. Look closely at the alpha agonists. While they primarily reduce aqueous production, one specific alpha agonist, aproclonidine, uniquely tackles both the numerator by reducing formation and it reduces that episcleral venous pressure addition at the end. Make sure you have that dual mechanism tucked away in your memory for test day, for sure.
All right, let's shift gears a bit. Section 3, anatomy of aqueous flow. Let's see how this builds biologically.
I want you to actively trace this path with me. The production phase, our Goldman numerator, begins right here at the ciliary processes. Specifically, it's formed in the non-pigmented epithelium of the pars placata portion of the ciliary body. From there, the fluid empties into the posterior chamber, flows smoothly right through the pupil into the anterior chamber, and finally it seeks out the primary drain, the trabecular meshwork, or TM, located right there in the angle. Once it passes through the TM, it enters Schlemm's canal and eventually empties out into the episcleral venous plexus. This TM route, this is our primary outflow path.
But there's actually a secondary drain we absolutely cannot ignore, the uveoscleral pathway. Here, instead of going through the TM, the aqueous percolates backward through the ciliary body and into the suprachoroidal space. Now, it only accounts for about 5 to 15% of total outflow, though it's typically a bit higher in younger patients. So why does this matter clinically? Well, because our most commonly prescribed class of daily drops, the prostaglandin analogs, like latanoprost, bimetoprost, and travoprost, they specifically target and enhance this uveoscleral pathway. But here's another vital board pearl for you. As of right now, there are absolutely zero FDA-approved surgical procedures that intentionally increase uveoscleral outflow. Meds can target it, sure, but modern surgery generally does not.
Speaking of surgery, let's look at how we physically manipulate that primary TM outflow to increase our Goldman denominator. These are great examples of minimally invasive glaucoma surgeries, or MIGS. Look at the trabectome handpiece on the first image. This device mechanically disrupts and actually removes a portion of the trabecular meshwork tissue barrier, reestablishing natural outflow. Now compare that to the eye stent in the second image. Instead of removing the tissue, this tiny little implant acts as an artificial conduit, completely bypassing the TM to shunt fluid directly into Schlemm's canal. Both of these brilliantly utilize physical engineering to drive up that outflow facility variable in our equation.
Moving right along, Section 4, Structural and Functional Damage. What happens when this flow system fails?
Imagine you've got a 65-year-old patient sitting in your exam chair right now. You look at these two optic nerve heads. The first one is your normal, healthy optic nerve. Just notice that thick, healthy pink neuroretinal rim tissue wrapping all the way around. Beautiful. Now look at the glaucomatous nerve next to it. Orient yourself to the superior and inferior poles. Do you see that dramatic focal thinning right at the bottom? That is your classic inferior notch. And because of exactly how the retinal nerve fibers route themselves into the optic nerve, structural death at the inferior pole of the nerve head will predictably manifest as a functional visual field defect originating in the superior nasal field. So, the anatomy directly dictates the functional loss. And notice how this glaucoma continuum maps out the timeline of this damage. Take a look at the green asymptomatic disease section. Retinal nerve fiber layer death, which is that structural change we literally just saw, actually occurs long before a patient notices anything is wrong, and way before we can even detect any visual field loss on standard automated perimetry. This is exactly why we rely so heavily on advanced RNFL imaging in the clinic. Honestly, if you wait for the patient to come in complaining of a visual field defect, or for it to show up on a standard test, a massive amount of irreversible axonal death has already happened.
All right, we've made it to Section 5, the diagnostic algorithm. Let's bring all this foundational knowledge together.
Okay, active recall time. Think about a 70-year-old patient who gets referred to you for an IOP of 28. You look at their nerve, check their pressures, and you highly suspect glaucoma. What is the absolute very first diagnostic question you must answer in your mind to classify this disease? I'll give you a second to think about it.
Got it? The answer is, what is the status of the angle? Is it open or is it closed? And let me be incredibly clear here, speaking to you as your virtual residency director. There is only one acceptable way to determine the status of that angle, and it is gonioscopy. You must put the lens on the eye. Never ever just look at a patient's anterior chamber depth of the slit lamp and simply assume their angle is open. You have to prove it with gonioscopy. That is a hard, non-negotiable clinical rule. So let's say you do your gonioscopy and the angle is wide open. Great, you are now on the open angle branch of the algorithm. Your next step? You have to determine if it's primary or secondary. How do you do that? Well, you have to actively rule out every single secondary cause. Things like pigmentary dispersion, pseudoexfoliation, trauma, steroids, the whole list. Only after you have actively excluded every secondary cause can you arrive at a diagnosis of primary open-angle glaucoma, or POAG. Remember, POAG is strictly a diagnosis of exclusion.
Now, to truly master this, you need to confidently contrast the risk factors between primary open angle and primary angle closure glaucoma. These are prime OCAP pearls right here. Look at refractive error. Myopia is a well-established risk factor for open angle, whereas angle closure is much more likely to occur in hyperopic or far-sighted patients who naturally have those crowded anterior segments. Notice the corneal factor for POAG. A thin central cornea is a massive risk factor. This was definitively proven in the Ocular Hypertension Treatment Study, or the OHTS trial. And finally, pay super close attention to the ethnicity risks. While Asian ancestry carries a high risk for angle closure, the staggering outlier is the Inuit populations of Alaska and Greenland.
Guys, their relative risk for primary angle closure glaucoma is estimated to be 40 to 50 times higher than individuals of European or African heritage. That is huge. Do not miss that on a test.
Ultimately, no matter which side of the diagnostic tree your patient falls on, whether it's open or closed, primary or secondary, your treatment always loops right back to our original physiological framework. IOP reduction is literally the sole arrow in our glaucoma treatment quiver. We manipulate the math of the Goldman equation to save the optic nerve from the irreversible structural damage we've seen today. The continuum of this disease is totally relentless, but our structured clinical understanding is what allows us to intervene and make a difference. So, as you head into clinic tomorrow, I want to leave you with this final thought. When you look at an optic nerve, are you just seeing a static cup-to-disc ratio, or are you actually visualizing the physical, mathematical, and anatomical forces actively shaping that tissue in real time? Keep that clinical reasoning sharp, and you will absolutely be well on your way to mastering glaucoma.